you for joining our second day Academy of Oral Surgery Summit. Today we have with us Dr. Pratindir Singh, and I will be introducing him shortly. Before we do that, I would like to share some information with you. Academy of Oral Surgery. This was our second day this spring virtual conference, and we had some of the really top world-class speakers today with us. You guys can obviously earn CEs for these presentations, and they are available for you guys to do that later. And there's a live stream on the Facebook. On the Global Summit Facebook page. Also wanted to share with you that we are offering a 1-year free membership of Academy of Oral Surgery. And you guys can do that by using this coupon code, the Global Summit, at the checkout, oralsurgery.org/register. We are so excited to announce that we had 500 new members joining us last month. And this is a great benefits here. So for the first year membership, we're offering this free again, and we are having some new announcements for our mastership and our fellowship programs, which we'll be announcing soon. Last thing, International Abstraction Academy is a hands-on workshop that we've had many of these, dozens of these prior to COVID. All around the U.S., and we're starting them back up again with our very own Dr. Thomas Wideman and Carlos Morao. And this is basically a lot of good information on oral surgery for general dentists, complications, and just how to do things without getting in trouble. So with all that said, we are having our very own Dr. Pratindir Singh. Dr. Singh is how are you doing? It's a pleasure to have you, Dr. Singh.
Thank you very much, Dr. Kewan.
Yeah, he's obviously a senior professor in the Department of Periodontology and Oral Implantology in SDD Hospital and Dental College in India. He's a chief editor of a Journal of Periodontal Medicine and Clinical Practice, and associate editor of various other journals around. There is many accolades here that I can go with Dr. Singh. I can read on and on and on. It's a pleasure to have you as a part of our Academy of Oral Surgery, Dr. Singh. We really appreciate you having you as a regent, and all you do for us. We really appreciate that. So without any delay, I would like to. This is Dr. Singh.
Thank you very much, Dr. Javed. It's a pleasure to hear from you. And good morning, good afternoon, good evening, good night to everyone around the world. So we are back again with our 14-hour series. The association with Global Summit is quite long and, very interesting. We are giving a lot of knowledge and hoping the best for the clinicians to, learn from our platform. And we are planning much in regard to presentations, our new programs, which Dr. Javed is going to tell you. He told you before, he's going to tell you after the presentation as well. So Global Summit is doing a great platform, and I am loving to be a part as an ambassador to India of the Academy of Oral Surgery, also being the chair position of Global Summit. So it's a great journey with the association of great colleagues. Dr. Kenar is really having a great ambitious views of Global Summit, and it actually means a lot. The world is knowing it, and thank you very much for giving me a chance to speak on the AOS Spring Summit. I'll be speaking on the role of blood and its products in regenerative dentistry and oral implantology. I hope people will enjoy today's lecture. warm welcome to all, and I will be speaking on the role of blood in regenerative dentistry and oral implantology. Myself, I'm a professor in periodontology and oral implantology, also an international ambassador of Academy of Oral Surgery, United States of America, and I'm one of the world's top 100 dental specialists as well. So before I start, as you all know, that COVID-19 is very much spreading. So be safe from coronavirus infection, be smart and inform yourself about it, be kind and support one another, stay safe, all because we care. There's a very famous comic, Marvel comic, and there is a character known as Archangel. So it was Archangel who can use his own blood to heal others. The blood has the power or the ability to have healing properties. Throughout the lecture, we'll see how we are going to see the effect of blood in regenerative dentistry and oral implantology. The power to have blood with healing properties is because of its healing and other properties. That's why it's also known as miracle blood, or also known as regenerating blood. Jesus has also mentioned about blood in the role of its divine healing. How wonderful to know that God has provided salvation through the blood of Jesus. So it's basically, the slide is to show that blood has some healing properties. It can give you deliverance. It can cleanse you from sickness as well as sin. And everyone can qualify and can meet the conditions the world sets forth. So basically this slide is to tell you all that blood has a lot of properties of healing, which we are going to discuss throughout our lecture. So basically there are 4 essential elements to the process of wound healing: immune and matrix cells and their communication, changes in the vasculature with angiogenesis, development of a framework and scaffold for cells, and establishment of a biological seal and space maintenance. So these are the 4 elements we need to require in the process of wound healing. Coming to platelets, the most important cells in the blood which we are going to use in our regenerative procedures. What's so special about platelets that the whole world is talking about platelets? Platelet contains granules that store large number of growth factors. Alpha granules, they're activated when platelets aggregate and adhere to the site of inflammation. They form an intracellular storage pool of proteins vital to wound healing. Many growth factors are released, namely platelet-derived growth factor, TGF, that is transforming growth factor, and insulin-like growth factor 1. So they all result in the expression of a gene sequence that directs various cells to proliferate. There is synthesis of collagen, osteoid production, and so on. So as you can see, for regeneration, we need cellular proliferation, we need collagen, we need osteoid for new bone, and so on. So with these growth factors, we get all of them together. It is the activation of platelets and release of various growth factors that makes them so special and is the key to enhance tissue repair and healing. Before we come to platelets, we should also know the role of a blood clot. A natural blood clot contains 94% RBCs, 5% platelets, and 1% WBCs, while I'm talking of platelets, or we'll be talking about platelet concentrates. They contain about 85 to 95% of platelets. So after, you all must be knowing, after a tooth extraction, there is the role of a blood clot in healing. So that has just 5% of platelets. If we're going to replace it with a platelet concentrate or a platelet gel, we get 85 to 95% of platelets at that site, and how is going to help will be discussed in future slides. Coming to platelet concentrates. Platelet concentrates are not stem cells. They are neither MSCs, that is mesenchymal stem cells. They are neither lymphocytes or bone marrow. Autologous, blood is centrifuged, and we have various concentrates such as PRP, Tprf, then we have LPRP, we have PPRF, and then we have LPRF. So P stands for poor, L stands for leukocyte rich, used alone or in combination with bone grafts, which the procedure is known as guided bone regeneration. Activated gelatinous matrix containing various growth factors, PDGF, PDAF, basic fibroblast growth factor, tissue growth factor, platelet-derived epidermal growth factor, platelet factor 4, insulin-like growth factor. They all together form a matrix for stimulation of collagen production, improved neovascularization and angiogenesis, and enhanced bone formation and maturation. And what we achieve in the end is enhanced qualitative and quantitative wound healing and regeneration. Various growth factors, PDGF, AA, PDGF AB, and PDGF BB, functions chemotaxis. TGF, that is transformer growth factor beta, helps in cellular proliferation, inhibition. BMPs, bone morphogenetic proteins, help in the repair of epidermis and inhibit keratinocyte proliferation. FGF are the fibroblast growth factor, angiogenesis and mitogenic function. Epidermal growth factor helps in proliferation and mobility of fibroblasts, keratinocytes. Vascular endothelial growth factor, as the name suggests, helps in angiogenesis and increased capillary permeability. Insulin-like growth factor, reepithelialization and granulation tissue formation, and finally interleukins, which help in pro-inflammatory functions. Now, when we classify these blood concentrates, we have the PPRP, that is without leukocytes. Then we have the LPRP, that is with leukocytes. Then we have the second generation, that is a platelet-rich fibrin, that is PPRF without leukocytes, LPRF with leukocytes, IPRF, which is the injectable form, APRF, which is the advanced form, TPRF, that is the PRF, which is formed in titanium tubes. The third generation platelet concentrate, titanium prepared platelet-rich fibrin. We'll be talking about them all. The autologous platelet concentrates, PRP and PRF, they are used in various medical fields in oral and maxillofacial surgery. These concentrates contains very high growth factors, including the 3 isomers of PDGF, that is PDGF-AA, PDGF-BB, and PDGF-AB. 2 of the numerous transforming growth factors, insulin-like growth factor, the EGF, that is the epithelial growth factor, and the VEGF, that is the vascular endothelial growth factor, which are the key elements in wound healing, particularly in bone regeneration. These concentrates of platelets are very easy to apply in clinical practice and offer very potential benefits, including rapid wound healing, bone regeneration, and can therefore be considered to be the new and the latest therapeutic adjuvants. Current clinical use of platelet concentrates in the world. You can say everything and anything. You can use it anywhere. Internet is marketing it for a host of elements. It's, kind of the snake oil of today. It cures rheumatism, grows hair, gets rid of wrinkles, etc., etc. Yes, it does wonders, but I'll be covering its role in regeneration of, dentistry and in oral implantology in my lecture. The various roles of these concentrates in dentistry, in sinus lift procedures, implantology, ridge augmentations, in socket preservations, alveolar cleft repair, oral nasal fistula repair, intrabony defects, jaw reconstruction surgeries, soft tissue procedures like gingival grafts, SCTGs for increasing the soft tissue healing, endoperio lesions, and also filling of various cystic cavities. So you can imagine what all plethora, what all the panacea of these concentrates is there in dentistry. Now, coming to regenerative dentistry, it entails the replacement of tissues lost to disease or injury with physiologically equivalent engineered tissues. Coming to the first, platelet-rich plasma. Platelet-rich plasma, also termed as autologous platelet gel or PRGF or the platelet concentrate, is essentially an increased concentration of autologous platelets suspended in a small amount of plasma after a brief centrifugation. Immediately prior to application, a platelet activator or agonist, in this case we use a topical bovine thrombin and 10% calcium chloride. They are added to activate the clotting cascade, producing a platelet gel, which is the platelet-rich plasma. The concept and description of PRP started in the field of hematology in the year 1970s, when hematologists created the term PRP in order to describe the plasma with a platelet count above that of the peripheral blood, which was initially used as a transfusion product to treat patients with thrombocytopenia. 10 years later, PRP started to be used in maxillofacial surgery. Platelets were thought to have only hemostatic activity, although in the recent years, a lot of research has happened and a new perspective on platelets and their functions has come out, that platelets contain an abundance of growth factors, as I already mentioned, cytokines that can affect inflammation, angiogenesis, stem cell migration, and cellular proliferation. PRP is a very natural source of P granules, and these P granules are degranulated, and then comes the release of growth factors and cytokines that modify the pericellular environment. Some of the most growth factors, as I already told you, is a repetition, PRP, the release from PRP, PDGF, IGF, EGF, matrix metalloproteinase 2 and 9, interleukinates. For preparation, usually 8 ml autologous whole blood is taken, 2400 RPM for 10 minutes in a centrifuge. We get a plasma plus buffy coat. Another 3600 RPM for 15 minutes, we get platelet poor plasma. And on one side, we get the platelet rich plasma. And on addition of thrombin plus calcium chloride, on activation, we get what we know want as PRP gel. In 2009, Dohan and Reyes proposed a classification of 4 main families of preparations showing 2 principal parameters in the presence or absence of leukocytes, that is pure PRP or leukocyte poor PRP. The preparation obtained is without leukocytes and has a very low density fibrin. Leukocyte rich PRP preparations contain a lot of leukocytes and show a low density after activation. Then we have the pure PRF or the leukocyte poor PRF. Preparations are without any leukocytes with a high density fibrin. And comes the leukocyte rich fibrin, that is the LPRF. Products are preparations with leukocytes and with a high density fibrin network. Now, everything comes with a limitation. Limitations of PRP, lack of uniformity in PRP preparation protocol, as different platelet concentrations have different storage time. This is quite a limitation. Release of growth factors is for a very short period of time, so you have to be very careful while you plan the surgery. The the sharing of growth factors of the release is for a very shorter time period. Concern is the use of bovine thrombin in activating the PRP. Sometimes it is people are not comfortable with the animal products, and also it is liable, or it is there to cause immunogenic reactions in few cases. So this is one of the main limitations of PRP. Coming to a case I'm going to discuss with you, effect of PRP on regeneration of intrabony periodontal defects treated with hydroxyapatite and collagen matrix using single flap approach as minimally invasive surgical technique. It was a split mouth clinical radiographic study. As you can see in this picture, we have used an acrylic stent to act as a for standardization. The probing depth, you can see in the first picture the probing depth, and you can see in the radiograph There's an infrabony defect, which we are going to treat with PRP and bone graft using minimally invasive approach. So in the minimal invasive approach, the flap is only lifted from the buccal side, and interdental papilla, as you can see, is left intact. The flap is elevated. You can see the interdental papilla is left intact, and the area is debrided and thoroughly cleaned. Now you can see the bony architecture, the mixture of PRP with the bone graft. You can see this mixture. Now we are going to place this mixture in the site. It was pushed onto the site, and the site was sutured with a mixture of PRP and hydroxyapatite. So this is the picture showing after a month of surgery. You can see the reduction in probing depths after 3 months. This picture is after 3 months. You can see we have gained the bone levels using a mixture of PRP and hydroxyapatite. And in this picture, you can see this is a picture at 6 months. Awesome decrease in the probing depths and a nice bone formation, almost zero infrabony defect. We can see in the radiograph showing the miraculous effect of PRP and a mixture of bone graft in treating this defect using minimally invasive periodontal procedure. So we had two groups. In one group we used only PRF gel, and other we used mixture of PRF with the graft. You can see the reduction at baseline at 3 months and 6 months. There was a great reduction of probing depths in which we used the PRF gel and the bone graft. Intergroup comparison of relative attachment loss. We had a great result if we compare the baseline to the 3rd month and the 6 months. Intergroup comparison of bone levels. There was a nice reduction. You can see graphically at 6 months, we had a very nice reduction from 3.75 to 1.93 in terms of bone loss. Bone fill was again very satisfactory and very statistically significant as well. Coming to the next, platelet-rich fibrin, the whole world is talking about, represents a new revolutionary step in the platelet gel therapeutic concept. This technique does not require any gellifying agent, but not more than centrifugation of the natural blood without additives. So this is the main advantage. No additives are required in case we are using platelet-rich fibrin. Dr. Chokran et al., Joseph Chokran, developed the PRF in 2001 at France, and the production protocol of PRF attempts to accumulate platelets and release cytokines in a fibrin clot. I've been lucky to meet Joseph Chokran in a conference in Thailand, and we were together for a while, and we discussed a lot about PRF. So he's done a great job in PRF and its future generations. Protocol is very simple and simulates that of PRP, includes collection of whole venous blood around 5 ml in each of the 2 vacutainer tubes without any anticoagulant, and the vacutainer tubes are then placed in a centrifugal machine at 2700 RPM for 12 minutes or 3000 RPM for 10 minutes, after which it settles into the following 3 layers. We have the acellular plasma, we have the fibrin clot, that is the PRF, and we have the red corpuscle base. And this is how you can see we separate out the high tensile strength PRF as a single entity. Oh, and it, while I tell you the uses, it is marvelous in terms of regeneration. Standard platelet-rich fibrin, that is SPRF, 2700 RPM for 12 minutes. Then we have the advanced PRF, that is APRF, 1500 RPM for 14 minutes. Now you must be thinking, what is this RPM and minutes? Decreasing the RPM while increasing the centrifugation time in the APRF group gave an enhanced presence of a neutrophilic granular site in the distal part of the clot. Now, what is the advantage of that? We have more osteogenic stimulation, and this is what we require. We require a lot of osteogenic stimulation when we are talking of regeneration. Coming to various types of PRF, we have the LPRF, that is leukocyte-rich PRF, dense clot of fibrin with a minimal interfibrous space. Cells are observed along the whole clot, even if they diminish in the distal PRF clot portions. Coming to the advanced PRF, we have the APRF plus, that is 1300 RPM, 8 minutes, and APRF liquid, 1300 RPM for 5 minutes. Increased interfibrous space, higher count of cells, more uniformly distributed inside the clot compared to the LPRF, and some cells might also be found in the distal part of the clot, which we require for a lot of osteogenic stimulation. Then we have the great IPRF, which is the injectable PRF formulation. Development of a PRF solution, that is IPRF, centrifuge at 700 RPM for 3 minutes, and its derivatives, that is IPRF-M, 700 RPM for 4 minutes, and IPRF Plus, which is 700 RPM for 5 minutes. They were developed or pursued with the aim to deliver a platelet concentrate to physician, which proved easy to use in a liquid formulation to be used alone or in combination with various biomaterials. Taking advantage of a slower and shorter centrifugation velocity, it is possible to observe a higher increased count of regenerative cells with an increased concentrate of lot of growth factors compared to other PRF formulations obtained at a very high centrifugation velocity. Then we have the Tprf, that is the titanium prepared platelet-rich fibrin, the third generation platelet concentrate. It is prepared in grade 4 titanium tubes. Blood samples, I have to tell you that the other forms were all obtained in the glass tubes. Blood samples are drawn from the antecubital vein collected in titanium tubes and centrifuged at 2800 RPM for 12 minutes. The Tprf, why is it made in titanium tubes, is based on the hypothesis that titanium may be more effective in activating platelets than the silica activators, which are in the glass tubes in Chokran's LPRF method. So that's why known as Tprf. Properties of Tprf: better hemocompatibility of titanium than the glass, more polymerized fibrin, longer life of Tprf in tissues. Various, we just discussed APRF plus, various RPMs and the minutes we have already discussed before. This is just a slide to show the various RPMs and the various minutes. We have already discussed about this. And now, is there any advantage of PRF over PRP? Yes, there are. No biochemical handling of blood. We are not adding any additives as calcium chloride or bovine thrombin, just the patient's own autologous blood. Simplified and cost-effective process. Use of bovine thrombin and anticoagulants not required. No chance of any immunogenic reaction because you are using purely autologous blood of the patient. Favorably healing due to slow polymerization. More efficient cell migration and proliferation. PRF has a supportive effect on immune system since it has no allergic reaction. So you can imagine what all advantages it has. Various applications in dentistry coming to periodontal regeneration, various root coverage procedures. Clinical conditions require good bone fill along with clinical attachment gains. In oral surgery, extraction sockets. If I tell you, it is great in cases of deep extraction sockets. If you use PRF, very less chances of getting a dry socket. Pre-prosthetic surgeries, periapical surgeries, implants, obviously to enhance osseointegration of implants and also to get beautiful soft tissue profiles in case of gingival zeniths in prosthetic planning of implants. In pediatric endodontics for regeneration of pulp tissue, damaged roots, cervical or apical dentine. In pediatric dentistry for pulp capping procedures. Showing you a case of PRF, case 1. You can see the immediate implant placed in the extraction socket. You can see this is the jumping distance. In the extraction socket, this is the implant placed. So we have added PRF inside the jumping distance to cover that and to act as a reservoir for great regenerative process. And this is how we have gained. You can see the pre-operative X-ray as compared to the post-operative X-ray after 6 months. What a great osseointegration and bone fill we have achieved by just using PRF in case of invaded implants. PRF case 2. This was PRF case 3. Coming use of PRF in case of open sinus or the lateral sinus lifts. We have used PRF. Now as I just told you, PRF to be used in extraction sockets. This is how PRF is used in extraction sockets, by just placing in the extraction socket and simply suturing it. PRF used in cases of ridge splits, in case of narrow ridges. Now, in this case, you can see this is the narrow ridge for placement of implant. We have started with the ridge split procedure in the bone. The horizontal and vertical, the bony parts are separated for a ridge split. The ridge has been split, and we are going to fill this ridge split area with PRF. You can see this PRF. We are going to add PRF and bone graft to this ridge split area. We have placed the implant and covered it with the remaining PRF which is left behind, and sutured the implant site. Evaluation of peri-implant soft tissue and crestal bone levels in dental implants placed in healed bony sites with or without PRF membrane and PRF liquid, a clinical radiographic study. So in this case, I have used PRF as a membrane as well as the remainder as a PRF liquid. Dental implants placed with PRF. You can see the edentulous site, the X-ray with the radiographic grid showing the edentulous site. In this case, you can see a very unique technique of dipping the implant in the PRF liquid. You can, for 30 seconds, we have dipped the implant after we have prepared the osteotomy site. We have dipped it for 30 seconds. It gets coated with the PRF liquid, and then we have placed the implant. After that, the membrane which was formed, we have covered the implant site with the membrane for a great soft tissue healing. So this was the X-ray which we have obtained at 6 months, and then 3 months, and this is the X-ray at 6 months, which was post the restoration. You can see an amazing crestal bone level and eventually no bone loss till now. The papilla fill index in these cases in which we use PRF plus PRF liquid versus only PRF, we have gained a lot of papilla fill. If we compare the papilla fill from the baseline to 6 months, we have gained a lot of papilla as part of using PRF gel plus PRF liquid. Crestal bone loss almost next to nil. Probing depths almost very less. Coming to its role in endodontics, the use of antibiotic paste for canal disinfection along with PRF strengthens the effective sterilization in carious teeth, infected dentine, periapical lesions, and necrotic pulp. The potential behind success of PRF as a super drug in regenerative endodontics was stressed by Huang et al., who concluded that PRF, when used in endo, causes proliferation of human pulp cells, which also increases the expression of osteoprotein and alkaline phosphatase. So I'm just surprised when we use platelet-rich fibrin in any field of dentistry, how it gives various growth factors, various enzymes, and various factors to just stimulate the various factors in our body for healing and regeneration. It's like marvelous to use PRF. Now coming to its role in pediatric dentistry, PRP and PRF, they are found to be much superior to routinely used calcium hydroxide in pulp capping procedures. As we are commonly using just calcium hydroxide, please give a try to use PRP and PRF because they are very tissue friendly, and there is no tissue reaction between these materials, as we sometimes have tissue reaction between calcium hydroxide in pulp capping procedures. Now, coming to, I'm just praising PRF, but yes, it also comes with certain limitations. Only a limited volume of PRF can be used because it is obtained from an autologous blood sample. Quantities produced are low. This fact limits the systematic utilization of PRF for general surgery. So in dentistry, we get a lot of amounts for our surgery, but in general surgery, the use is not much of, in terms of quantities. PRF tissue banks are unfeasible. The fibrin matrix cells, they contain all the circulating immune cells, which are all highly antigenic plasmatic molecules. That is why PRF membranes are totally specific to the donor and cannot constitute an allogenic graft tissue. So PRF tissue banks are unfeasible. Let's see what the future holds on, but it is autologous, so it's not, we don't need soft tissue banks, it can be easily made. Coming to the next concentrate, concentrated growth factors, or the CGF. Like PRF does not require the addition of bovine thrombin or an anticoagulant. Furthermore, altered protocols in obtaining the blood sample and the centrifuging procedure compared with PRF. Unlike PRF, CGF is prepared with 20 to 60 cc of patient's venous blood, centrifuged at 2400 to 2700 RPM using a specific centrifuge with an air rotor turning at alternated and controlled speed for 12 minutes, resulting in very rich fibrin blocks, which are much larger, much denser, and rich in growth factors than our common PRF. How is CGF prepared? Acceleration for 30 seconds, 2700 RPMs for 2 minutes, 2400 RPM for 4 minutes, 2700 RPM for 4 minutes, 3000 RPM for 3 minutes, and finally the last step of deceleration for 36 seconds to a final stop. Special centrifuge for the preparation of CGF. This is one of the ones we use by Medifuge by Silfridan, Italy. The resulting fibrin clot or block is of a very high quality, and the concentration of fibrinogen, factor 13, and thrombin that is obtained. Factor 13A, which is activated by thrombin, cross-links the fibrin clot to increase stability, lot of strength, protection against plasma-mediated degradation, hence a very longer shelf life in the human body. Clot with higher tensile strength, 1.5 kg after 1 hour versus 500 grams. Adhesive strength, decrease in hemostatic time. Essentially, the CGF, you can say, is an upgraded version of PRF with a strengthened fibrin matrix and boosted growth factors with cytokines. Pedontal ligament cells cultured with CGF membrane showed a marked increase in osteogenic markers such as collagen 1, bone proteins, and osteocalcin. A superior phase represented by the serum, as you can see in the figure, we have the serum, then we have the interim phase, which is a buffy coat, we have the growth factor plus stem cells, then we have the platelet-rich coagulations. So this is how we obtain the CGF. CGF membranes are used to cover wounds or reconstructed areas which can stick together thanks to a lot of adhesive property of CGF and their elasticity. They can be sutured very well. So we can also suture a CGF, though we can also suture a PRF membranes, but the stability of a CGF sutured membrane is amazing. At the end of the surgery, the wound can be brushed with the serum which is left behind. CGF case 1, you can see a very compromised case, the sinus, which requires a sinus lift for implant placement. So in this case, we have planned the use of CGF. So a lateral window approach, you can see the window has been created and implants placed, the sinus is lifted and CGF is inserted. A lot of CGF is inserted in the lateral window, and you can see the scan where how the sinus has been lifted properly with the implants placed, and a very nice sinus lift with awesome bone formation. At 6 months of the scan, we can see the role of CGF in great efficacy in terms of sinus lift, showing its great results. CGF case 2, it can also be used in root coverage. You can see a Miller's class 2 or 3 defect. We have lifted the coronally, we are going to use the coronally advanced flap. We lifted the flap, the root surface is very nicely debrided, and we are going to root biomodify the surface by using 24% EDTA for 30 seconds by burnishing the root surface. The CGF membrane is very nicely sutured. As I told you, CGF membranes can be very easily sutured. We sutured the flap, coronally advanced flap. This is the result obtained at 3 months with almost zero defect. The root was almost covered, showing great results of CGF in root coverage. Now, as I showed you, we use CGF in a case I just showed you. We did not use any bone augmentation. We just use CGF. So the no bone added sinus augmentation has many advantages, such as infection is not reported, significant higher new bone formation is achieved than bone graft added sinus lift. Patient's morbidity is very low because the harvesting of autogenous bone is not required. The risk of cross-contamination from bovine and human bone is eliminated. Surgical costs can be reduced. I am actually now in quite a lot of favor of doing sinus lifts with only PRF or CGF without using any of bone grafts, with great results. And also the results are what I'm talking about. They are very well reported in literature. Coming to the next concentrate, again a very great one, the MPM, or the mineralized plasmatic matrix, also known as sticky bone. Dr. Son has been using and led to the concept of sticky bone, a way to prepare the particles of bone grafting or substitute that makes it malleable, stable, and enhance the penetration of growth factors inside the graft. 12 to 15 minutes at 2500 RPM. You can see how we have obtained by the MPM. It is, the MPM, we take the fluid out of the test tube into a syringe. We mix it with the bone graft, and we can just pick up this bone graft in one go. It's like very sticky. You can pick it up as one piece, hence the name sticky bone. So we are going to use sticky bone in case of MPM. You can see in this case, we have to place an implant. After the placement of implant, there is the absence of buccal bone. It was covered with the MPM and the flap was covered. You can see we have covered the flap with MPM. After 3 months, we have again opened the site, and after the gingival former was removed, you can see the excellent gingival zenith we have achieved for the placement of the prosthesis. Sticky bone case 2 by Son et al. As I told you, it can be picked in one go. You can see this is just picked with the help of a tweezer. This is the power of sticky bone, and it has a lot of properties. It is going to be used in this case of showing you ridge defect. We are going to use this sticky bone in this case. The implants are placed, and we need some width in this case. So we have induced some bleeding points in the bone for blood. Mix the bone to create MPM, and you can see we have covered the implants with a mixture of mineralized plasmatic matrix or the sticky bone, and hence then we have covered it with a membrane, and this is what we have obtained at the surgical site. You can see amazing bone levels, amazing ridge, which wasn't there at the pre-surgical stage. The implants are at great levels using MPM, and they were restored properly. MPM is a natural evolution of PRP and the PRF. It enhances transportation of the material by securing its implementation. The interesting part in the MPM is the mineral fraction, which is either autologous bone or any other bone graft or bone substitute. For making sticky bone, it's your choice. My choice is usually autologous bone or a xenograft. This mineral part is not present in old autologous growth factor membranes such as PRF or PRP. So this offers the MPM the stability and the resistance to the chewing forces. So in terms of healing, if we say if the patient is a bit non-compliant, MPM plays a greater role in resistance to the chewing forces, and we get amazing result with the use of MPM. Now we have discussed various forms of blood, the power of blood, the platelets, the PRP, the various forms of PRF, CGF, We have talked about MPM. So we have a jungle of platelet products out here. It's the clinician's choice. It's what do you want? What is feasible at your clinic? What technique is going to give you excellent results? So I am not stressing at any fact that you use PRF or CGF or MPM. We have discussed everything. It's your choice, your case. Please go ahead with the use of these concentrates in your profession, and you'll obviously get positive results with these platelet products. And I'm also working, I also told in my last lecture, I'm working on PRF in my research, and going to come up soon with something related which I'm not able to disclose right now. I'm coming up with a form of PRF which is going to be another form of PRF for regeneration with few additives. It's going to be out soon, and let's see if we get a chance. We'll be discussing all the cases with another form of PRF as well, and hope it was of use to you all. So again, thank you very much for being a great audience.